Welcome to Soft Cock Appreciation Week 2024. I invite you to get comfortable as you join us for what I like to call cockversations, discussions, or grown folk putting their heads together and sharing ideas in authentic and real ways. Now be aware we don't hold back in our language, and what follows is not for overly sensitive or easily kerfuffled ears. And before we dive in, remember, what is shared here is not meant to be, nor is it a replacement for medical advice. Whenever you notice changes in your body or that of a loved one, especially in how the penis is functioning, please seek out medical consultation. What the penis is saying could literally save a life. Thank you for supporting us. If you take away something useful from this, please let us know, write a review, spread the word, and keep coming back for more. Are you ready? Let's do it. Hello, welcome to Soft Cock Week 2024. I'm Erica Leroye, your hostess, and I am very excited today to have with me someone who I have put my own body into his hands many a time over the last few years, Dr. Justin Smitherman, who has been helping me with my hormone regulation as I've come into menopause. And I have just found every time I come to your office, I feel like I learn so much. The way that you explain things, the way that you help me understand what are the normal changes that I'm going through as I age, what the different hormones are that we've been, dialing in, how I'm supposed to understand my own regulation, things I can do to enhance what the hormones are doing, why we were doing it in the first place, making good choices. I just have always felt like, And one of the things about Soft Cock Week that part of the reason that we do this is that for so many men, they don't know how to put a care team together, right?
Yeah.
That maybe they go to a doctor, a traditional doctor, maybe they go to a urologist, and then they go to, maybe they start with their family doctor, if they go to a doctor at all, right? They go to their family doctor sends them to the urologist might send them to a pelvic floor PT, maybe that person sends them to a sex therapist, but there's so much runaround. And so part of what we're doing this year with Soft Cock Week, Soft Cock Appreciation Week, is also really enhancing what are the other types of care providers that are out there who are working with men's health, and especially men's sexual health and body awareness and body acceptance, so that people know what the options are. So Dr. Smitherman, you are a functional medical doctor, chiropractor, naturopath. Am I missing something?
That's it.
That's it. Okay. So really so much. And, and you're not woo, right? I want to make it clear to people. Like, that's one of the things that I love is we're both on the West Coast.
Yeah.
Which is nice because the work that you do and the work that I do is more available to people because of that. But this is not a woo conversation. So sometimes people around the world or in other parts of the country, they hear naturopath and they think, oh, that's not, what is that? So do you want to just start maybe by saying just something about your approach to working with people?
Yeah. So I think that the first important thing that you said was people do get the runaround, and there's a couple of reasons why. So the first reason is that a long time ago, there was one study done on rats where they gave rats a tremendous amount of testosterone and they all got prostate cancer. And sometimes you look at a study and before even reading it, you're like, well, of course this will happen. This makes total sense. How would this not happen? And the example I always use with people is, everything has a right amount. And if you have too little or you have too much, you're probably going to run into a problem. And then the next thing I say is, if you drink enough water today, you will die. Every person on this planet could drink enough water and it could kill them. It'll dilute the sodium in your blood and that's it, right? So if you don't have enough water, you also die. Testosterone's not quite on that level, but there's a right amount to have. And in the beginning, they just did I'm sure not on purpose, they did research that scared doctors at that time.
Mm.
And so what happens often in the medical community is things are just passed on. And when new data emerges, it doesn't mean that that new data is going to be utilized. New things can come out and not be in vogue for 20 years, 30 years. It could just take so long. So first you have the old ideas of what testosterone is, what it does, and how it affects the body that have carried on from doctor to doctor to doctor through the generations. And then also, when you're dealing with your primary care doc or urologist or someone like that, those types of specialists, you're also almost always dealing with insurance companies.
Mm.
And insurance companies have defined low testosterone levels as, for men, as 2 tests separated between 7 and 9 a.m. in the morning that are below the minimum cutoff of that test. So the lab I use is Quest Diagnostics, and for males, the bottom is 250 total testosterone. So if you're at 249, you are not normal, and if you are at 251, you're normal, right? Mm-hmm. So that is probably not, in my personal opinion, the best way to approach this or to help people. But, it's the guidelines that are out there. And the last reason is, especially primary care doctors, I think they have a very difficult job, because every single person that comes in, they're just seeing so many different problems. And I think it's probably difficult to get your brain to go from, hey, here's my patient who has lymphoma and I'm working with their oncologist and here's the things that I'm doing. And then the next patient is like, oh, you have a sprained elbow. And then your next patient has erectile dysfunction.
Right.
I don't know how they do it. That seems so difficult to me. And so, there's probably a lot of discomfort. And you can definitely find primary care docs and urologists and endocrinologists who are going to be comfortable with it, who do it all the time, and who will have a philosophy of treatment that would match what I'm doing. But if you want someone who sees probably thousands of testosterone patients over their career and does it every day, all day, there are a ton of testosterone clinics. Mm-hmm. And this is my opinion. If the greater medical community was doing a really spectacular job with hormone replacement for men, then I wouldn't exist, right? Mm-hmm. So obviously there's a reason and there's a market for these testosterone specific clinics. And these testosterone specific clinics, they're ran by medical doctors, osteopathic doctors, nurse practitioners. There's PAs there. There's all types of different providers who are at these clinics. And I would really separate them into 2 types of clinics. There's one that's really out there for your money, and they're just they're mills, they're testosterone mills. And then there's ones who actually care. So that was, when I was listening to your intro, that was the first thing that stood out. And I think a lot of guys will come to my clinic and they'll say, hey, I have all of these symptoms, testosterone symptoms, and they'll list them all out. And then they'll say, my primary care doctor ran my levels. It's 300. I have all these symptoms. And they said, sometimes you get older, or something like that.
Right.
Probably not the best approach.
Well, I mean you're bringing up a couple questions that I have. I do work mostly with men who have erectile issues in some shape, manner, or form throughout the lifespan. But certainly there comes a point in mid-age where the body is changing. You can see it. The musculature change, the belly gets softer. There's just there is a change. And in the world of women's healthcare, we have these names. We have perimenopause, we have menopause. We've identified that part of the natural aging process is that these important hormones shift, and that it makes sense. We used to not live so long. We didn't really need them for procreation anymore. Let's let them go. But I get all the time men saying, oh, maybe I have low T, or my doctor says I have low T, but I can tell that they don't even know what that is. So can you describe for people, both for people who are watching and listening, their partners? I think a lot of women have zero. When I say andropause and low T, most of my female friends are like, I didn't know that that was a thing. Is that what my partner is going through? Is that what my husband is going through? Let's talk about low T first. And then what is testosterone? And then what is like, what does it do? Why do we need it in the first place?
Mhm.
And then what is like the natural arc? And what is it that now, thanks to science and medicine and observation, we're able to say, well, we're no longer only living to, 40, and there is a reason to keep it.
Mhm.
And what is it that people can do if they want to in order to enhance the testosterone function? So give us like the overview of, because this is what I love about you. You're so good at this, is what is it? What is its natural function and arc? And what are the things that people might start to notice as shifting? And when they do, what's available? What can they be thinking about?
So, testosterone is one of a lot of hormones in our body. You have testosterone, estrogen, progesterone, luteinizing hormone, follicle stimulating hormone, thyroid, growth hormone. There's a lot of them. And men and women have testosterone. We both need testosterone, just in different amounts. Um, when you're going through development, the testosterone helps to develop the male characteristics, to develop the penis and sperm, body hair, all the deep voice, everything that you associate with male. And then as you get older, it continues to have function, sex drive, importance in your bone mass, fat distribution, muscle mass, red blood cell production, sperm production. There are, if you think about what a hormone does, you can think about where are the receptors for that hormone. You have testosterone, and more broadly, there's another word called androgen. That testosterone is very specific, but a broader term is androgen, which includes many. Um, where are those receptors at? What tissue do they have, a docking site on? Your heart, your kidney, your brain. It's all over the place. And I think that when you're looking at what is the natural changes or the natural evolution of a person over their lifespan, there's two important things, like two important points I think that can come up. The first one is we've been testing testosterone levels in males since the 1950s. And if you look at the 1950s, 60s, 70s, 80s, 90s, 2000s, all the way to today, our testosterone as a population in the United States is getting reduced. So we're actually having lower levels of testosterone over time. The issue with that is we have not evolved or changed as humans in that amount of time, but what's going on with us has changed. And
Can I ask you, are they seeing that like already sort of in the development, like in child and adolescent development, that it's low, like in the same way that they're seeing like that there's higher estrogen, like in milk and those things. So they're seeing more estrogen in childhood. Are they seeing lower testosterone, or are you saying that, oh, like more in adulthood, the levels are lower,
yeah,
or is it throughout the whole?
I don't see any pediatric patients, but I would assume that it's true that there's lower. The youngest patients that I see are about 20, and even in 20-year-olds. So we have really good data for adults. I'm not sure how it's changed
Okay.
in younger people. I would assume that it has changed though. And if you look at, that's not the only thing that's changed, right? Like all of our chronic diseases are up. We have obesity, heart disease, we have diabetes, cognitive decline, everything that's chronic pretty much has increased over time. And there's a lot of reasons, and people argue about the reasons. It's probably a combination of a lot of reasons. Um, Changes in our food, changes in our stress levels, our sleep habits, the chemicals in our environments. Um, there's so many changes in how we live and function as a society over these decades, and it's obviously resulted in problems, chronic disease problems. And low testosterone could be categorized as a chronic disease problem because it's not healthy and it's not what it should be for us as a population. So that was the first point. And then the second point that's really important is what's normal. A decline in testosterone is normal as you age. Also, um, becoming cognitively less sharp, losing your elasticity in your ligaments and your tendons, reduction in your athletic ability. Yeah, like aging is normal, right? Dying is normal. So if you ask, an 80-year-old, hey, do you wish you were getting around like a 30-year-old? I bet they'll say yes. So what's normal and what's desired are not necessarily the same things. And people will say, what's your lifespan and what's your health span? So lifespan is how long you live, and health span is how many healthy years do you have? Because you could become decrepit at 40 and live to 80, but they might not be healthy years. Can you travel? Can you perform all the functions you want to perform? Are you happy? Do you have the abilities you want to have? And so when I'm looking at the decline in testosterone, what I see is that it may be that a decline is normal. I think we're declining more than is normal for throughout history right now. So it's a problem. But even though it's normal doesn't necessarily mean it's desired, right? So, and I've tested a lot of guys on their testosterone, and I can tell you the guys who are 50 and their testosterone levels are 800, 850, those guys are healthy and like doing well, right? And then the guys who come in and they're in the 300s, they're not doing well, right? So I think that's really important, is to make those 2 points. And I think we're all looking, you can tell by the popularity of health podcasts and things like that, we're all kind of looking about, as we age, how do we age gracefully? How do we age and be able to still do things that we enjoy and love? And testosterone can definitely play into that for males and females.
Great. So let me follow up on that specifically, because one of the things that many people enjoy and love is sex. Two things that we're really trying to bring forward. One is, however you show up for a play date is totally fine. You don't need to always be hard. But for men, that's very hard for them to penetrate, so to speak. Right? That it becomes, if I don't have what I'm used to, if my body doesn't do what it always has done, then this isn't good. And so part of the reason we have Soft Cock Appreciation Week is to help people get off of that mental track, because that doesn't do good for anybody. But the other part is that often we see changes in erectile function or ejaculatory function, sexual function overall, change in arousal and libido as a signifier years before other things are, like often the penis is saying, hey, there's something going on in the system, years before you might get something in, where the heart finally is like, you haven't been listening, now I'm going to give out, or, something else. So what is it, what would people be noticing in their sex drive or in their sex life and their sexual function that could be a signifier that, maybe it's time for me to be checking or learning more about how my testosterone and any other hormones are
are affecting me? Because that might be showing up in a sooner or in a different way, but people don't think about it.
I think it doesn't hurt to check. And there's been plenty of guys who will come in and I'll check their testosterone level and I say, I understand you have a problem. It's not your testosterone. So
Okay.
you have a problem. That's not it. Or you think you
Mhm.
have a problem or you feel you have a problem. That's not it. So getting checked is not too big of a deal because it just gives you information and you can find out and I'm just going to review this. I know you already know this, but when I'm thinking about erectile function, I'm thinking about how's your blood flow, which you touched on with the cardiovascular disease. Yeah, you're going to have erection problems probably before you have a heart attack. Blood flow, hormone levels, what medications is this person taking? Because especially the psychiatric medications they're hard to overcome. They can create erectile dysfunction and make it very difficult. What is this person's general health level? Are they active? Are they fit? Are they doing exercise activities? And what is their both internal and external psycho-emotional? This is more what you do. What's going on there? How are their relationships? How do they feel about themselves? Do they have anxiety? Do they have depression? Are they in a really bad relationship that is causing a problem? So all of those things matter. And for me in my clinic, I'm really focusing on what are your hormone levels and how is your blood flow? And for the blood flow, the easy thing that I think everyone does is prescribe blood flow enhancers, Viagra, Cialis. There's some natural medications that you can take, but really exercise is better. And I think of those things as short-term solutions. And yeah, I mean, it's probably not that big of a deal to stay on them for a long time. In fact, tadalafil, which is generic Cialis, has a lot of evidence of benefit over long periods of time for reduction of many different diseases. But I always tell people, hey, if you do 20 minutes of cardio a day, you're really going to be paying yourself a good salary on your health there. So I think all of those things need to be addressed, specifically with testosterone. If you want to try to separate what is physical and what is psychological or emotional, I ask guys, do you wake up with an erection? So this just happened maybe 2 days ago. I'm talking to someone. He has a new girlfriend. They're doing sexual activity, and he's having erectile dysfunction right now currently. And I asked him, I said, do you wake up in the morning with an erection? He said, every single morning he wakes up with an erection, like good to go. And I told him, this is not physical. If it was physical, you wouldn't be getting them when you are relaxed and when your brain shut off. Your brain is stopping you from getting these erections. So that's one really important distinguishing factor. And I think if you're not waking up with erections, it could be blood flow, hormones, or medications. And then if you are waking up with them, it's probably something else.
Okay. So let's say I come to you, I'm a man, I come to you and I'm having some erections, but I've lost my drive. I've lost, like, that's something we hear, right? Low libido. I just don't want it, right? You're talking about somebody who is like, I want it. And it's more like, I'm coming to you because my wife or my partner or my boyfriend, my husband has a high sex drive. And I'm afraid I'm going to lose my relationship because, I used to want it and I don't want it anymore. Would that be something that is testosterone connected? Because we hear that, right? Low libido, that like libido and testosterone have some kind of relationship.
Yeah, it can definitely be it. In that case, sometimes, people will come in and they'll say, we have 5 kids and I have no time and I work 65 hours a week. And
Right.
then I say, well, that's important and that's a contributing factor.
Sure.
And then other times it's also relationship problems. But if a person, so when I'm looking at testosterone levels as a basic guide when I'm first talking to someone, I tell them the first thing is when I'm looking at your symptoms and I'm looking at your levels, I can give you, an estimation of how likely I think it is that you'll be happy with testosterone therapy.
Mm.
So if a guy comes in and his level is 200 and he has, he's not able to get and maintain an erection and he has low libido, I say, this is a slam dunk. I feel very, very confident that you are going to get a benefit from this and you're going to be happy with this treatment. Everything, is just your best estimation. So, I mean, if 100 guys come in and they're all in that same scenario, I think 95, 97 of them are going to be happy. And then there's going to be a couple of guys who it's not it. Maybe it's a contributing factor. There's more going on. You have to do some digging. But if a guy comes in on the opposite end and their level's 870, I think there's a very low chance that
Mhm.
this is the problem. And I could be wrong, and I've been wrong, but you flip those numbers. Now, out of 100 guys, it's going to not be the issue, 90, 95% of the time. And then there's a couple of different types of cases. When you're looking at the libido, I think that it's even more common people have low libido than they have the inability to get or maintain an erection. It's so common. And I think a lot of people it's circumstance with libido and it's emotional and psychological and relationships and time and energy. And if you're so tired that you get home and your head hits the pillow, you're probably not going to
Yeah.
feel like engaging in sexual activity.
Yeah. No, that's very true. That's very true. I want to ask you about numbers, but before that, I wanted to share. So this is interesting. I just want your thought on this. I had a client where his testosterone was it was 112 when he started to see me.
Yeah.
Okay. And they didn't put him on testosterone. And we had 5 sessions over the course of 2 months.
Mhm.
Mostly it was a little bit of sexological body work, but primarily it was just human connection, right?
Yeah.
There was a little cuddling, there was some intimacy, there was some conversation. He got retested in December and his level was 800,
That's amazing.
right? And
Yeah.
then stopped working with me. And then in July went back down to 266 and then
Wow.
down to 92. And again, relationship, his primary relationship was not very, he mostly came because he was touch deprived. But I thought that was fascinating. Like with no other changes, he went from 112 to 800 in September, October. The reason I'm looking down is it's in my notes
Yeah.
here. So September, October, November, December. We started working in late October. So in 2 months, just having positive, warm, human connection
Yeah.
that had arousal as part of it. I mean, there was definitely the juiciness of, dance and touch and movement and all of that. But I mean, that says a lot,
That's insane. I
right?
wonder, was he pretty depressed? And
Yeah.
then, yeah, so probably working on depression too. And
Well, the oxytocin, my
yeah,
sessions are so oriented around how high can we boost your oxytocin
yeah,
receptors, right? Like, how can we get the oxytocin going? But that made me curious, like the relationship between like oxytocin. I think a lot of men who are depressed are kind of in this cortisol, adrenaline,
yeah,
loop. And I'm curious what your thoughts are about how testosterone, because we're saying depression and we're saying anxiety, but it's actually like if your body is circulating more adrenaline and cortisol than it is like positive dopamine, serotonin, and oxytocin, what's happening with testosterone in relationship to those other hormones?
yeah. So there's this is me. What I'm about to say is just like my opinion and my thoughts and things like that. It's not. So there's a popular concept called pregnenolone steal. Basically, you have cholesterol, and then this is simplifying it, but cholesterol, pregnenolone, and pregnenolone is also called the mother hormone because it's giving birth to all your other sex hormones. And pregnenolone is either going to become cortisol or it's going to become DHEA. And then if it becomes cortisol, it's going to go into your body and be cortisol. If it becomes DHEA, downstream from that, it becomes estrogen, progesterone, testosterone, dihydrotestosterone. Like all of those sex hormones are coming from that. So you only have so much pregnenolone. Imagine if, you're trying to fill up 2 buckets and you have a water source. If you're taking your water source and you're pouring it all into your cortisol bucket, you don't have any water left to pour into your DHEA bucket. And then how are you going to make testosterone? How are you going to make your sex hormones? It's called pregnenolone steal, and cortisol is stealing from DHEA pathway. And I think that definitely happens to people, and it can be significant, particularly if you're vulnerable, because if you already are a person who doesn't have enough pregnenolone, and then you start shifting your pathways towards cortisol, you don't have enough building block in the first place, and now you're shifting it all towards cortisol. If you had an unlimited supply of pregnenolone, then it would matter a lot less because you could fill up both of those buckets and you have the raw material. Everyone is so different and our vulnerabilities are all different. Just like one person smokes and they get lung cancer at 40, another person smokes, they're 100 and they go snowboarding and hit a tree or something, right? So that's a really interesting case, I think.
So would pregnenolone, is that how you said it? Pregnenolone, when you say it's sort of, is that kind of like we're born with a certain amount, or are there things that we do? Are there things that we can do? Like, is that something that exercise helps, diet helps? Like what, like, I've never heard that in terms of like something to boost or to be cognizant about. So how does that work?
You make it from cholesterol. So,
you make it.
you make it from cholesterol, so you can keep making more. But the amount that you make of pregnenolone, it's just the same as anything else in your body. How many resources do you have? How much cellular energy do you have? Are you rested? Things like that. And your body's just going to prioritize based on your lifestyle. And also you are born with your own predispositions. 2 people are going to be born at different testosterone levels that they have a proclivity for. And just like anything else, you're going to see some people are 7 foot and some people are 5 foot. And it's the same thing with hormones, which is why looking at the levels is only part of the story. Because if a person is an anomalous person and their level, when they were young or where they're supposed to be is, say, 1300, which is actually above the reference range that we currently have, but that's that person and that's their normal. And then they test at 500. It's like, okay, 500, you're within the range, you're normal, you fit into the box. But if you as a specific individual, you're just you, and it doesn't mean it's normal for you. What's normal for you could be much higher. And on the flip side, if a person is taking anabolic steroids and they're running their levels at, say, 1500, but they're meant to be a person at 600, they might not respond very well.
That makes sense. So since you, now I want to circle back to just this range, because, I was recently at the Prostate Cancer Research Institute's conference for patients and caregivers, which was wonderful. But what I noticed is boy, when you work with the male population, medicine becomes like baseball stats, right? It's a lot of like, what's your number? You've got a
Yeah.
Gleason this, and a da-da-da this. It's very like, I noticed like, oh, this is different than like what I experience in women's healthcare. So obviously everything, whether it's male, female, or gender fluidity, lab tests are lab tests, and there's numbers that we're looking at. So when we talk about range, what is like range of testosterone for sort of like peak period of life is generally what? If someone goes to the doctor and says, I want to get my testosterone checked, they go to a lab, right? That's a blood draw.
Hmm.
Do they have to do it at a certain time of day?
Yeah, 7 a.m. to 9 a.m. in the morning is the best time to do it. Sometimes people are night shift workers and things like that, and that can change.
Okay. So they go in the morning, they get their blood test. Do they have to do it fasting?
It doesn't matter.
It doesn't matter. Okay. And then they get a number. And a number comes back. And what is like the in general, what's the range that I mean, everything that you've just said, I want to be clear, is I love that you're saying it's totally individual. So one thing that we can say, which is really good, because again, part of Self Cock Appreciation Week is just helping men and their partners be their own health advocates. So one thing is to get a baseline, right? If you
Yeah.
don't know
Let's
anything,
say,
you don't know anything. So you get a baseline, and your baseline is if a baseline number that makes you say, I'm not too worried about this, but as we keep retesting, let's see where you go. What's the range of baseline that makes you say this feels like your testosterone is in a good place?
mhm. The way that the range is, the way they come up with the range is it's a bell curve of the population. So you test a sample of the population and you do a statistical analysis on it and you figure out what markers do 95% of people fit within who are like normal. And if so it's interesting because depending on what lab you go to, they'll observe a different range.
Hmm.
So some labs, the top of that range is 850. Some of them it's 1100, and some of it's 1250. So on the bottom, I think pretty much everyone kind of agrees on a 250 bottom. So I use Quest Diagnostics between 250 and 1100 total testosterone. When you initially test someone, you also want to test their free testosterone because even though we talk a lot in totals, what is actually interacting with your cells and what's actually biologically available to make changes to a person or to interact with a person is unbound free testosterone. So essentially, you have testosterone, it can be bound or it can be unbound. And if you think about it being bound as being its hands are tied, it can't do anything, it can't do any work. It's bound up by proteins, albumin, sex hormone binding globulin, things like that. And so when I'm looking at what's normal, you have to recognize that the first thing is this range has actually shifted over time. The range used to be higher, and now the range is lower because as a population, our testosterone is lower. And because our testosterone is lower, when they do the statistical analysis to get 95% of people in the box, well, 95% of people are going to fit into a box that's a lower range. That's the first thing to think about. On either side of the range, 2.5% of people who are normal will fit outside of that box and they're normal. How they're defining normal is basically this person, it's funny because you could be tested and have erectile dysfunction and they'll still classify you as normal.
Hmm.
So abnormal is like a very ill person, not like a healthy person in the population, which what does healthy mean, right? Um, so when someone comes in, I'm really just pairing their level with how they feel and what symptoms they have. And if a person comes in and I'm breaking it down based on the total, not the free, and I'm breaking it down and I say, what do I think is the likelihood that you would feel better or improve from a higher testosterone level? This is the way I think about it. If you're below 400, I think it's very likely that you are going to be a person who would benefit and be happy from a higher testosterone level as a male.
Mhm.
If you're in the 500s, so basically 400s or below, I think you're going to be happy. And the lower you go, the more likely you'll be happy, right? When you get into the 500 levels, it's really a coin toss. Someone comes in, their level's 550. If they're 550 and and that's paired with low testosterone symptoms like low motivation, difficulty building muscle, weight gain, a weight distribution that's towards the bottom half of their body, not growing facial hair well, inability to get and maintain an erection, low sex drive, if they're low energy, if they're coming in with those symptoms and a 550, it shifts me towards, okay, like we should give this a try. If they're coming in with a 550 and their only symptom is, I feel tired. I say, okay, like I'm shifted now towards I don't think you're going to be happy with this therapy because there's a million reasons why you could be tired. And someone doesn't say, I'm tired. And I say, oh, you just need testosterone. Come on. So it's a coin toss in the 500s. And then when you get into the 600s, it's just less likely. And if the 500s are a 50-50, when you get into the 600s, it's maybe 80-20 or 70-30, where 70% of guys are not going to benefit or feel happy with the therapy. And as you continue to go higher, the percentage just gets less and less. When you get into, say, 700, 750, something like that, I think it's 90-95% that you're not going to be happy with the therapy.
That makes sense. Thank you. And so one of the questions that brings up for me is, especially when I think sort of in my man brain, I want like high numbers must mean like I want it as high as possible, right? So is that true? And B, are there any risks involved with having higher levels of testosterone, and what would those be?
Your man brain is correct. More and more and more must be better.
Right.
So the first thing is there's diminishing returns on testosterone level. The things that guys are looking for and looking to get out of it, if you're somewhere on therapy, on replacement therapy, if you're between 850 and 1,000, say you're at 1,000, if you double to 2,000, you're not going to feel twice as good. You're not going to have twice as much of all the benefits. If you're at 2,000, this is an astronomical number that people shouldn't be at, then you increase to 4,000, it's not going to double again, right? So there's diminishing returns, and there's a Goldilocks number for every person.
Mm-hmm.
I say that Goldilocks zone is somewhere between about 850 to 1250. For most people, 1250 is too high. For a lot of people, 850 is too low. If a person can hug 1,000 total testosterone, for the majority, like the large majority of guys, at about 1,000, and I would tend towards 850 to 1,000, so like 900.
No matter how old they are, or is that in a particular period of life?
It really doesn't matter. It's
okay.
I have my youngest patient's about 20, and my oldest patient is, I think, 76. And what a person can handle is just very, very, very unique to them. I have people who are running at about 1,200 on their levels. They have no side effects. They feel great. They're doing great. They're healthy. Their labs look amazing. And then I have people who will get to only 800 And it's like, whoa, now you have acne, you have oily skin, your red blood cell, I'll get into this, but your red blood cell levels increase, your blood pressures increase. You as just a unique individual, you can't handle this. This is not the level for you, right? So everyone's very different. But most people, like if you're just looking at like regression to the mean, about 1,000 is pretty good, 900 to 1,000. And so when you're looking at even at age, if you look at the tables, as people age, the level comes down, right? The level is coming down because people at that age, if you were to analyze them, this is a more normalized level for them. But then you go back to the same thing of, okay, well, great. 20-year-olds probably don't have degenerative disc disease, and 60-year-olds probably do. And if you ask all the 60-year-olds, hey, do you like this degenerative joint disease? They're going to say, no, I wish I didn't have this. My knees hurt, my back hurts, my shoulders hurt. And then you ask a bunch of 20-year-olds, how are your knees holding up? They're great, right? So if we were to plot like what's normal for your knee as you age, and then you come in at 65 and your knees have grade 4 osteoarthritis, that's normal. You're fine. This is exactly where you should be. It's normal and you're great. So get out of my office, right? It's just how you think about it.
Well, that's interesting because I feel like that is, though, when we're talking about the penis, that is what a lot of men end up with, right? Is that they go to the doctor and they say, I'm, 60, 65.
Yeah.
I'm now predominantly soft, even when I feel some arousal, this is what's happening. And the more often than not, what I hear is they get because you're 65. Right.
Yeah.
And even for me, I mean, there are times where I'm working with people and I'm like, you're not 20. And so that gets, and I think that's the difference. It's interesting because that's sort of the difference between what is the part that's body acceptance, which is you're not going to have the erectile function of a 20-year-old when you're 65.
Absolutely.
And how do we just then be okay with where our body is? Because when we're freaking out about it and we're producing more cortisol and we're producing more stress hormones but I want to be what I once was.
Mm-hmm.
And we instead accept that, of course, our body changes over time, that's fine. And also, what is your baseline? Get your numbers checked, take a look and see. And if there is something that is like, oh, maybe there is something going on, there's some options. So I want to kind of, as we're coming to time, I want to ask a couple things. So one is, so if someone decides boosting my testosterone is the way for me, I want to explore this more. This is something I want to do. Now, I know, and I know that I'm currently on testosterone. Right? That's part of, like, a woman can go on testosterone too. And we decided that because when I went through menopause, my clitoris receded, right? So I had sort of, for the first time, I had kind of a whole empathetic thing with my clients, which is, hold on. Like, I used to always, like, I knew how hard my clitoris was going to get. And I knew that if I touched it like this, I'd have this kind of sensation. And I came to you saying, oh my gosh, I feel like I don't know where my button is anymore. It had receded and my libido went down. And so when we began, I was doing injections. And then after a year of doing weekly injections, I realized that was not going to be sustainable for me. My skin didn't like it. I didn't really like jabbing myself. And so now I use pellets. So what are the ways that men, and I know some women with hormones, like more with estrogen or progesterone, they use creams or patches. So for men who are interested in boosting their testosterone this way, what are the options that are out there for them? What's the delivery method? Kind of, because I know there's information, but I don't know what it is.
So a lot of people will say, do I need testosterone? Can I boost my testosterone naturally? And get enough sunlight, get enough rest, reduce your anxiety, the things you're talking about with oxytocin, lift weights, maintain a low body fat percentage under 15%, for example, eat healthy, high quality foods, and have good relationships, right?
Yeah.
So it's everything that everyone should just be doing anyways.
Mhm.
And there's some really specific things. For example, sleep apnea is a testosterone killer. If you are snoring in your sleep and you're stopping breathing in your sleep and your blood oxygen content's going down, fixing that one thing could boost hundreds of points, potentially.
Wow.
Potentially. Um, so that's the first thing. So a lot of times when people come in and I tell them these are the things that you can sort of naturally do to raise your testosterone, they say, duh. Like who does? I know. Hey, you're telling me have less stress. Great. Well, I should quit my job and move and
Right.
just whatever. Um, if you are going to do a replacement, I think the best options are pellets, creams, and injection. And I don't think it matters what way you do it. I think it matters if it fits your personality and it fits you uniquely in how your body accepts it. So, and the reason I say that is because I have guys on injections and pellets and creams who are happy. I always say, are you safe and are you happy? If you're safe and you're happy, then it's a job well done. But I also have people who will start off with pellets and say, oh, I think pellets are not the way for me. That was horrible. I didn't like that. Okay, I'm going to do cream. And then they love the cream. And then guys will start on the cream and they'll say, oh, this is horrible. Who does this? I hate this. And then they'll go to the pellet. So I think a lot of it's just finding what works best for you. And there's not one way to do it. Those are the three ways. There's some things that are probably not great. There's an intranasal testosterone where you snort it. And I had one person try it. And before he tried it, I said to him, I think this is not a good idea. I really don't know who's doing this or why this exists. And then he did it and he calls me, a few weeks later and he's like, my nose is so raw and I
Oh.
can't do this anymore. um,
Yeah.
yeah. There's sublingual troches where you put it under your tongue and it absorbs through the mucous membranes in your mouth. Um, it peaks up really fast and then it drops really fast. I think that especially financially, because it's very expensive, to give a guy the amount of testosterone that they need, it would be difficult. They work really well for women because women just need a lot less. So it's easier to do it that way. And then there's an oral testosterone where you take it by mouth. I don't think it's a good idea. We find that something new comes out and people say, this is good, this is fine to do, and wait 10, 15 years and you're going to realize, well, that wasn't good or fine to do. And me personally, I don't prescribe the oral. It has to get processed through your liver. I don't do it. I think that eventually people are going to figure out this wasn't a good idea. Particularly to get people to therapeutic levels, the amount that you would have to take to get to a level where you feel good, I just don't think it's smart. Um, those are all the ways to do it. There's a testosterone patch, which I think you could just call it akin to doing a topical method, a cream.
Great. Great. So, two more things. So, one is you're in Washington, and if someone wants a consult with you, do people have to come to you directly, or do you offer telehealth? Like, how can people who are watching this and listening to
Yeah.
this find more, be able to connect with you?
So I have a license to practice naturopathic medicine in Washington and Oregon. And I also have a DEA, so a Drug Enforcement Agency license in Washington and Oregon. Right now, because of COVID, there's a holdover of you are allowed to prescribe and treat people medically with DEA controlled medications from video visits.
Mm-hmm.
It wasn't always like that. In the past, there were restrictions that you had to see a person physically, face to face in the same room, ever so often, every 6 months, every 12 months, depending on what the medication was. When COVID officially ended, the official end of COVID, when that happened, the DEA, they wanted to switch it back to the old rules where you couldn't do the telemedicine visits anymore to prescribe these types of medications. And they got something like 50,000 angry comments. Yeah, where people were really mad about that. So they didn't dispense with that rule completely. What they said is they're going to continue to suspend the rule, and they one day might try to implement it again. But the way it is currently, I can see anyone in Washington and anyone in Oregon through telemedicine or in person and prescribe these types of medications. When you look at the large testosterone clinics, what they do is they just have people with licenses in many different states. It doesn't make sense for me to I could get licensed in California, Arizona, Vermont, New Hampshire, whatever, but it just doesn't make sense for me because even if you can see people all over the place, just for me, I'm not like the best internet person ever. So typically it tends to be more of a local thing for me.
Right. Okay. But if somebody had questions and they weren't coming to you for a prescription necessarily, but just if someone said, wow, this seems like someone who could actually answer my questions and kind of help guide me towards advocating for myself. Is that something that you can do with someone if they're in Ohio or New Hampshire or somewhere else? Is that something that you offer?
If it's not a state that I'm licensed in, then it'll put some restrictions on how I talk to people and what I can say and the way I say it. And the difference would be, it could be a small difference. It could be, I think you're a really good candidate for testosterone therapy, and this is a treatment that I recommend for you. It wouldn't quite be like that. It would be, I've seen many people in your situation who have benefited from testosterone, and I think you should seek out someone who can, give you more information on that. So it's just a little bit different.
Okay. And we'll put a link to your website and your contact information so that people, can find out more. And if that feels like something that they want to pursue, if they're local, I definitely recommend coming to see you. And if not, having more conversation. And then the other piece, which is connected to this, is do you have any final tips for people being their own advocate? Because there are, in terms of talking to their doctor, talking to one of these clinics, like what are the things that you would say, if you're going to pursue learning more about, is this right for me, what are the questions that I should ask a provider so that I feel like I can be comfortable and that they know what they're doing?
I've seen that lots of people are doing things incorrectly if they don't do it on a regular basis. And it doesn't matter when the case is easy. I say case because it's a caseload of patients. It doesn't matter so much when the case is easy because, you don't have to fine tune things as much. But when the case is hard or the person needs very specific individualized things that aren't cookie cutter and aren't following, whatever the general mass recommendations are, then it's difficult and it takes some work. The real key is managing side effects. When people are having side effects, you have to know what to do. You have to know how to handle that. You have to be able to help this person. And one thing that happens the most often is someone has a side effect, and then the doc who doesn't probably manage testosterone very often says, okay, stop. And then you're just going back to all the symptoms you originally had. But you need tools in your toolbox to say, oh, you're having this side effect. This is how we manage this side effect. Here's how we go forward, where we can both help you and also make sure you're safe. And the first thing I would ask is, how many people do you manage on testosterone? If they're like, oh, I haven't prescribed this in 4 months, that's probably not the best person to go to. But if they say, I've done it, I've seen it, I've been there, I know about all these things, and I currently have, hundreds of patients, that person probably knows what they're doing. And your only risk in that situation is that they're a mill, and like a prescription mill. Like they don't really care. Yeah. Like they're just making lots of money. And with the mills, what probably happens is, if they get 100 patients and 70 of them are those easy slam dunk patients, the other 30 will go away. They'll keep the 70. They'll get another batch of 100. They'll keep 70. And they're just building. And if you're an easy patient, you're fine at a mill, because you don't need the specialized care that another person might need. But if you start off at a clinic and you're not doing well and they don't have solutions for you, go to another clinic. Mm-hmm. Don't stick with them.
I really love that as a takeaway, that we're asking, is this something, how often are you doing this? How familiar you are with prescribing testosterone? And then I really like that takeaway of, and what is your approach if I have side effects? Like that's like a really good, like if you're talking even to the front desk person as you're trying to get information, what is your approach if I have side effects? Because if they can't answer that tells you something. If they can't answer, but they say, let me find that out for you, that's important. And if they say, we never have people with side effects, that tells you something, right? Right. So I love that. That's a great health advocacy tip.
I heard something from a doctor in Portland, and he said, if a doctor tells you that they don't have side effects in their clinic, they're not very busy. Because if you see enough patients, you will have side effects.
Okay, good. That makes sense.
Yeah.
That makes sense. Great. Okay, so this is fabulous. Thank you so much for waking up and starting your day with me. I'm really excited to share this with everybody. It's been really helpful. I think we've hit all the key points. Yeah. And, again, I just want to say to people, however you show up for sex is absolutely fine, right? You can have an incredibly enjoyable time with or without being hard.
Yeah.
And if you are noticing that you have some low arousal, low libido, erectile changes, and you have taken some time to assess your stress, your exercise, your diet, your overall well-being, and you think, and especially if you haven't already taken a look at your baseline, or if it's been a while, having some awareness that testosterone does change over time. And it changes. I've learned a lot today that it also changes, not just in a trajectory of from 20 to 60, but it can also be dependent on what is happening in your life. So having an awareness of testosterone, being able to, as I always say to my clients, especially if you have insurance, get these things looked at, because for the mind, it can be helpful just to be able to know it is this or it's not this.
Yeah, absolutely.
Right. So great. That is a fabulous end to our day.
Thanks for having me. I appreciate it.
Thank you. I'm so grateful that you're here. We will put a link to how to get in contact with him and get more information. Okay. All right. Thank you, everybody.